very good afternoon, everyone. My presentation is on neuro-ophthalmic manifestation of head trauma. Head injuries are common cause of visual impairment in head trauma patients. So early detection of neuro-ophthalmic symptoms is very important for diagnosis, management, and the prognosis of patient. But unfortunately, due to periorbital swelling and hematomas, this is delayed. My aim is to determine neuro-ophthalmic findings in patients with head trauma and to correlate with severity and type of head injury. Uh, it is hospital-based cross-sectional study of 25 patients of more than 10 years age group. It is done in a period of 3 months in tertiary eye care hospital in Chhattisgarh from December to March. My inclusion criteria are patients with definite history of head trauma with ophthalmic symptoms who have good level of consciousness and who are more than 10 years age group. Exclusion criteria is below 10 years age group and who are unable to come for follow-up. My method of data collection is after taking proper ethical committee decision and proper consent, I took history of patient regarding head injury, the level of consciousness, ENT bleed, etc., visual acuity with Snellen's chart, color vision with Ishihara chart, pupillary response by torchlight, and anterior and posterior segment examinations. It was followed by X-ray head and orbit with NCCT head and orbit, and results were interpreted. My statistical analysis was done by SPSS version 22 software by two-tailed method and assuming type 1 error and probability p-value less than 0.05. Result were study participants ranged 20 to 50 years and it was male predominant. Results showed maximum head injury were due to RTA followed by self-fall, assault and blunt trauma. My vision at presentation of patients were mostly falling in category of 660 to 160, 1 by 60 and no PL was found in 4 patients. Orbital fracture floor was the maximum fracture I saw, that is 7 patients, followed by medial wall 3 patients and lateral wall for 5 patients. This is the clinical profile of soft tissue injury, which shows that ecchymosis and subconjunctival hemorrhage was most common among all. Result: most frequently encountered neuro-ophthalmic abnormality was optic neuropathy in 13, that is 52% of patients. They showed RAPD, and efferent pathway defect was found in 12, that is 48% of cases, in which oculomotor nerve palsy was most common, followed by trochlear nerve palsy. These are the neuro-ophthalmic manifestations found in my patient, which we can see optic nerve injury was the most common among 76% of patients, followed by oculomotor nerve palsy, abducen nerve palsy, diplopia and ptosis. Result is mode of injury didn't correlate with outcome. Presence of any neuroimaging abnormality was significantly associated with neuro-ophthalmic deficit, and presence of orbital wall fracture was associated with trochlear nerve palsy, while contusion was associated with traumatic optic neuropathy. The severity of head injury was compared with the patients having RAPD or not, and we saw that maximum patients with severe head injury had RAPD. Discussion. Head injuries often affect visual system, making detailed eye examination crucial for assessing injury and prognosis. And epidemiology of specific neuro-ophthalmic findings might be helpful for clinician to have a higher index of suspicion. Road traffic accident was the most common cause of head trauma, and young males were frequently affected. Ophthalmic manifestation in my study included soft tissue injury in 46.6% of cases, orbital fracture in 13%, and neuro-ophthalmic abnormality in 10% patients. The most common orbital fracture is blowout fracture, where the direction of impact is from front, and our study has similar findings. In our study, oculomotor nerve palsy was the most common, followed by trochlear nerve palsy, in line with study done by Van Stavern et al. The abducens nerve, though prone to injury and commonly involved in palsy, was the least affected in our study. Among the afferent pathway deficit, optic nerve injury was the most common. Our study showed indirect optic nerve trauma more than direct one. Neuroimaging abnormality, that is skull fracture. Yes, ma'am. Ma'am, my study was done among 25 head injury patients. Yes, ma'am. Yes, ma'am. My study was done among 25 patients with head injury who were more than 10 years age group and having some neuro-ophthalmic or ophthalmic manifestation. So I concluded that in my patients, maximum patients were having optic nerve injury, that is afferent pathway defect was found in most of patients, followed by efferent pathway defect having most common oculomotor nerve palsy, followed by trochlear nerve palsy.
You told in the beginning the GCS score.
Yes, ma'am.
So you have excluded. So why you have excluded?
Ma'am, I have excluded because for neuro-ophthalmic manifestation, I have to see color vision of patient and I need some cooperation from patient for visual acuity. That's why I included only conscious patients whose GCS was good.
But I think those are the patients who would actually have a lot of neuro-ophthalmic manifestations because that will skew your findings. It would be better like you follow them up after 4th or 5th day when the GCS becomes better, because then your manifestations, everything will change. Because you yourself have concluded that the ones who had contusion had more problems, and any on CT if they had any imaging findings, they are more likely to have the neuro-ophthalmic findings.
Yes, ma'am. I found the orbital wall floor fracture.
I just meant that you should have also included the ones with a very poor GCS score, because they are the ones who will have more
findings. Yes, ma'am. Sure. Thank you.
Ma'am directly mentioned, so you can label it as a GCS score, that amount will go for 9, 8 or whatever. You can just label it. It is otherwise it is a tag. So many questions may come that way. And you are mentioning one of your slide, X-ray. Is there any role of X-ray and today's era?
Sir, like patients with poor socioeconomic class come to us. So first of all,
are you from a private hospital or
government
college?
setup?
Is it available or not? CT scan.
Sir, CT scan is available, but X-ray is very
no. That's so
common.
we generally always we tell as a so poor socioeconomic is a insult to this patient, because in government everything is free. Even in the private there is no such role. Even we need a MRI, we can go for a very quick scan of CT. We can save so many money, so many years. Quick scan. There is a term is a quick scan. No need for any CT scan, as all of you are maximum resident. And if you are thinking for that maximum time, we may go for a MRI.
Yes, sir.
Or MRA.
Yes, sir.
There is no such role of CT scan. If required to rule out only one condition, then only you can go for. You will be in trouble then in competitive session. If monsoon you may want that thing is the art. Okay.